Welcome to an audio pearl of the American Acne and Rosacea Society. My name is Stacy Moore, and I am the Executive Director. I'm pleased to introduce today Dr. Jim Del Rosso, the current President of the American Acne and Rosacea Society. He is here today featured discussing the current perspective on the management of rosacea. Dr. Del Rosso, as many of you may know, is the Dermatology Residency Director at Valley Hospital in Las Vegas, Nevada, and he works for the Las Vegas Skin and Cancer Clinic. What's new in rosacea, Dr. Del Rosso?
Well, it's exciting to be able to report that we have some new research information on rosacea. And in 2009, Rich Gallo's group published an excellent article in Journal of Dermatologic Science on the molecular pathology of rosacea. And in this article, they review several areas that relate potentially to the pathogenesis of papulopustular rosacea. And I think as an aside, that's very important. When we're talking about what's new in rosacea, we need to be specific regarding the subtype, because papulopustular rosacea and what contributes to papulopustular rosacea may not be exactly the same as what contributes to, let's say, development of phymatous rosacea, or maybe ocular rosacea, or even erythematotelangiectatic rosacea, which is the situation where patients just have the red face, the central facial redness, and no papules and pustules. So we have to be specific regarding the subtype of rosacea that we're talking about. Specifically with papulopustular rosacea, there's new evidence that stimulation of innate immune response, and this appears to be related to some degree to an increase in cathelicidins in the skin, which are antimicrobial peptides. And that has to do with a change in how those antimicrobial peptides are catabolized by an enzyme called serine protease, which is increased in the skin of individuals with papulopustular rosacea. What that does is it increases the production of some variant peptides that are pro-inflammatory. And this is some of the information that has come out of Dr. Gallo's lab in University of California, San Diego. And additionally, patients also appear to have an upregulation of toll-like receptor 2, which is one of the receptors responsible for stimulation of an innate immune response. And this has also been shown to be present in patients with papulopustular rosacea. So these are some new areas that can actually correlate with some of the treatments that we have and potentially some new treatments. Additionally, we know that patients with rosacea have an upregulation of reactive oxygen species, which probably relates some degree to photo damage also that can be occurring in these patients because the condition is on their face. And along with this, there is an increase in some of the matrix metalloprotease enzymes, which are responsible for maintaining the integrity of the dermal matrix. And we know that patients with papulopustular rosacea and also with erythematotelangiectatic rosacea have dermal matrix degradation within their skin. Additionally, some patients, although we don't necessarily consider this to be papulopustular rosacea, can present with a clinical presentation that may look like papulopustular rosacea or can simulate papulopustular rosacea and also facial erythema, and that can be due to an overgrowth of Demodex mites, and that's been defined in the literature recently. We don't necessarily consider that to be rosacea in and of itself, but it can look very much like rosacea, and it may be important to distinguish that because that will help direct your treatment. The other part of the whole pathogenesis puzzle is that patients with rosacea, and this is true of both the red face without papules and pustules, which is erythematotelangiectatic rosacea, or patients that have central facial erythema and papules and pustules, which is papulopustular rosacea. There's a dysfunction of the epidermal barrier, which correlates with why patients have sensitive skin. And we know that at baseline, even before we enroll patients into a study, when they're not on any treatment yet, that anywhere from a third to half of the patients may have stinging and burning or tingling of their skin. They may have some scaling, they may have some dryness, and that scaling is not necessarily seborrheic dermatitis. It's very different than classic seborrheic dermatitis, so we're not talking about seborrhea rosacea overlap. We're talking about patients that only have rosacea and can have some scaling and dryness of their skin. These patients have increased central facial transepidermal water loss, which accounts at least partially for why they have sensitive skin. So there's a whole host of things that are going on that can correlate with the pathophysiology of papulopustular rosacea, which we can direct our therapy toward controlling. And when we do that, we certainly see improvement. We don't see cure because we're not necessarily getting rid of the underlying cause or drive of the disease, but we're suppressing some of these mechanisms so the patients have a decreased frequency of flares and a decreased intensity of the signs and symptoms of the disease when we treat it. And we can do this best for papulopustular rosacea.
How do you differentiate treatments in rosacea?
Well, I think the first thing is to look at the patient and determine from their history what they've used, how they've used it, and how they've managed their disease in the past, because they may have been given medications that would be appropriate, but they weren't necessarily told how to apply them. We know that patients with erythematotelangiectatic rosacea do not consistently respond, and many of them often do not respond much at all to a lot of the approved therapies that we have, whether it be topical therapies or even some of the systemic therapies that we have for rosacea. Whether they're FDA approved or not, quite frankly, the medical therapies that we have are not very successful for erythematotelangiectatic rosacea. They are, however, if they're used consistently, very helpful for papulopustular rosacea. So it's really important to look at the subtype of disease. And additionally, if patients have ocular rosacea, which is not very severe, where they don't necessarily have keratitis, involvement of the cornea, but they may have some conjunctivitis and blepharitis, where they have eyes that feel scratchy or sensitive or irritated, the patient's thinking that they have allergy, but indeed they have symptoms of ocular rosacea. The systemic therapies we have, like tetracycline derivatives, are helpful in controlling at least the mild to low-grade moderate ocular rosacea type symptoms, the conjunctivitis and the blepharitis. So that's important to distinguish too, because that may help you determine if you're going to add a systemic therapy where maybe you weren't thinking of doing that because the patient had very mild disease that you were only going to treat with a topical agent. If they have phymatous rosacea, where they're developing rhinophyma or a proliferation of phymatous chains on the chin, let's say, or the forehead, which can also occur, and this happens more in males, you may want to get aggressive with some physical modalities like carbon dioxide laser to remold the skin, because there's really no medical therapy that's going to change the fibrosis and the sebaceous hyperplasia. Other than potentially isotretinoin, if you catch them early enough, you can reduce the sebaceous hyperplasia. But once they have a fully developed rhinophyma, for example, you're probably going to need to use a physical modality. Now, the background erythema and telangiectasia, whether it's patients that just have red face, central face, the erythematotelangiectatic type, or that persistent background erythema, what I call rouge erythema, in patients with papulopustular rosacea, that is typically not going to respond completely to medical therapy. And you'll often need to use maybe intense pulse light or some type of laser directed against the telangiectasia to reduce that component of the disease. So to summarize that, you basically have to look at the patient, really determine what subtype they have, and make sure they understand the therapy that you're giving them and what it will do. If it's going to reduce papules and pustules, and they come back and say, well, that wasn't really what was bothering me as much as these little red lines or this background redness, you have to make sure they understand the therapy you're giving them and what it is going to target in terms of how their skin looks. The symptoms will often improve, especially with papulopustular rosacea. If they have stinging, burning, and skin sensitivity, and you give them therapy that improves the disease, the symptoms will follow in the majority of cases in terms of the response.
In your clinical experience, what are some of the resources that you use and or tips for your patients?
Well, it's very important to recognize that most individuals that come in with rosacea are not very well informed, or they don't really know anything about the disease. It's not like acne where people know what it is, and they have all kinds of preconceived notions and myths that they believe relate to acne. Rosacea, a lot of times they've looked up things on the internet, they looked up red face, and they come in thinking they have lupus, and they're testing you to see if you have the correct diagnosis. No, you don't have lupus, you have rosacea. So you have to educate the patient about the disease and make sure that they understand that it's not something that you can cure, but at least with papulopustular rosacea especially, you can control very effectively with the medical therapies that we have. I happen to like, as a brochure, this is my own personal preference, there are certainly other patient education tools, but I happen to like the brochure that's provided by the National Rosacea Society. I think it's very well written. I think the pictures in there are more appropriate. There's not a lot of pictures in there that just show the worst cases where the patient opens up the brochure and says, oh, am I going to look like that? And the patient's not listening to you because they're afraid that they're going to have this big bulbous nose like W.C. Fields, which is not applying to this situation at all. I think the National Rosacea Society patient education brochure is very well done, but you can't just hand them a brochure and tell them, just read this. You have to give them some basic background about the disease, and I make sure that all my staff are on the same page with what I would tell the patient. I give them a basic review, and the staff reinforces it. Then we will write out for the patient, tailor-made for them, exactly what we want them to use in terms of skincare and the medications and how they incorporate them, so they leave with something in writing to know exactly what they need to do, how, and when. That's very important. Skincare is not just an adjunct that you mention as an aside. It's an integral part of the treatment of the disease. Proper skincare will reduce the symptoms and the signs of the disease to some extent before you even give patients any other therapy for papulopustular rosacea, and it will also improve to some degree erythematotelangiectatic rosacea. So the skincare information, in addition to any medical therapies you prescribe, have to be explained together and emphasized as everything being important.
Could you share with us a brief summary or an overview of the topical treatments in your experience and in your review of the literature? How do you differentiate from them, and just provide an overview of them?
Well, a lot of people wonder if I have a life because I spend a lot of time writing a lot of information, reading a lot of literature, and writing a lot of information on the medical therapies for rosacea. And we have to recognize that medical therapies have been primarily studied and almost exclusively studied for papulopustular rosacea. And all of the therapies that we have approved by the Food and Drug Administration in the United States are approved only for papulopustular rosacea. And the reason for that is that's what you could quantify. You can count papules and pustules and quantitatively look at whether a therapy is working. It's a lot harder to do that with judging erythema in a quantitative way, though you can do general global assessments of erythema. So when we talk about medical therapies and we talk about what's available in the literature and typically what we do in practice, the majority of what we're talking about is for papulopustular rosacea. Certainly with the topical therapies, topical metronidazole is very well established. We have some formulations that are very nice in terms of the vehicle formulation, like the 1% metronidazole gel vehicle, and even the older branded 0.75% was a very nice water-based vehicle. And those are examples of tremendous advances in when we think of a gel, we think of it as drying, but these gels are water-based and not drying or irritating in the vast majority of patients, and they deliver the drug very well. We know from several studies that topical metronidazole reduces papules, pustules, some of the erythema, primarily the perilesional erythema, and maybe a little bit of the background erythema, and also can reduce symptoms. So that's certainly a therapy that's been well established. Azelaic acid, which is available as a 20% cream, that's approved for acne. A 15% water-based gel approved for rosacea. Actually, that 15% formulation, at least based on the data we have, delivers more of the azelaic acid in the skin, and that's what is recommended for rosacea and approved for rosacea in the United States. Works very well also. There are a subset of patients that may experience a tingling or a stinging, and we can't necessarily predict who those patients are. It tends to be not a large number of patients overall in terms of having to discontinue the drug. The vast majority of them, it's transitory and it's relatively mild, and it goes away usually within the first few days to a week. And you can mitigate that by having the patients use appropriate skincare, which is something they should be doing anyway. Occasionally you get a patient that just can't tolerate it, so they stop it. And that can happen with the other therapies too. But with azelaic acid specifically, there may be occasional patients that just will tell you that. So if you warn them, they know it's going to happen. And it's, in my experience, it's rarely that much of a problem in terms of interfering with the therapy. And this is also a very effective therapy in reducing erythema, as far as perilesional erythema, some of the background erythema, and the papules and pustules. So this is also very effective and is well established in many different studies. A little bit new information on azelaic acid. It has been shown, at least in some concentration-dependent evaluations by Dr. Gallo's lab, that it actually does reduce the activity of some of that serine protease activity that catabolizes the catalycidins that I referred to earlier, and also can downregulate to some degree toll-like receptor 2. So in addition to its mechanism to reduce reactive oxygen species, or I should say the neutrophil burst, I should say, and metronidazole has been shown to do the same thing in some studies, azelaic acid may be working through some other mechanisms that have been identified. Sulfacetamide sulfur, it's an older therapy. It's been basically grandparented in by the Food and Drug Administration. There is some data on it. It's not used quite as much, but is beneficial in some patients. So those are the major therapies that we typically use, but I find myself going to the ones that are the best established and the ones that seem to work the best, and that's azelaic acid or metronidazole as topical therapies.
Can you talk a little bit about a brief summary of the systemic agents that you use?
Well, for papulopustular rosacea, the mainstay have been tetracycline derivatives, and you can use really any of the tetracycline derivatives. However, most recently, most of the data has focused on doxycycline, and doxycycline, as with the other tetracycline derivatives, can actually downregulate several mechanisms that have been correlated potentially with rosacea, primarily this increase in matrix metalloproteinase enzymes, and also that serine protease activity. It's been shown can be influenced by tetracycline derivatives. But the majority of the information we have specifically for rosacea is with doxycycline. Now the question is the dosing of doxycycline. And classically for years, we did not have any oral therapy that was approved by the Food and Drug Administration for any form of rosacea. And we've used these oral antibiotics, primarily the tetracyclines, for several years based on clinical experience. And we've been using antibiotic doses. There really is no definitive evidence that you have to suppress a bacterium to improve rosacea. The literature really does not support definitively that you have to have an antibiotic effect to improve rosacea. So when we're treating a chronic disease like rosacea, it's optimal to think about the fact that you don't have to use antibiotic doses or often very high doses for the treatment of papulopustular rosacea. A therapy that is come into vogue primarily because you can treat patients with a lack of antibiotic effect, but still get an anti-inflammatory effect that is very effective in many patients, is anti-inflammatory dose doxycycline, which is a 40 milligram capsule that partially releases the drug rapidly up front and then partially releases the remainder in an extended release fashion. And there's one particular formulation that is FDA approved for papulopustular rosacea, and that particular therapy has been shown in several studies to have the anti-inflammatory effect of the doxycycline without the antibiotic effect. The advantage of that is it appears to be as effective as giving a patient 100 milligrams of doxycycline, which does have an antibiotic effect. So the advantage of that anti-inflammatory dose, that 40 milligram capsule once a day, is to have effective treatment of the disease without the chronic antibiotic effect and the antibiotic resistance. That's really the main point that differentiates that particular therapy. But both are effective. As far as the efficacy, they're both there, but one has an antibiotic effect chronically that can contribute antibiotic resistance, and the other one does not. And the clinician has to decide how important that is to them. To me, that's very important. Others may argue that it's not, but it's hard for me to find people that say, I want to be on an antibiotic, especially long-term, when I don't need one. So that's my argument in favor of when it is effective, and it often is, using the anti-inflammatory dose that's not antibiotic, provided the patient can get access to the therapy.
Can you summarize what your clinical experience is or what you have read as well on laser treatment for rosacea patients?
Well, with regard to the lights and lasers, patients that have the background persistent erythema after you're treating papulopustular rosacea, that just will not go away, and it typically, some of it lingers to some degree. It's really hard to get that to shut off completely. Or patients that have erythematotelangiectatic rosacea often do very well, though they're not going to be completely suppressed, indefinitely, but they'll do very well with intense pulse light treatment. And also, there are certain vascular lasers that can be directed against the linear telangiectasias. Not being someone that does laser myself, I'm really not the best person to say this is the type of laser that's best for a specific situation. But it's very important to work with someone that is really up on selecting the proper lasers for the telangiectasias, and that really has in their practice someone that is able to deliver intense pulse light in a fashion for that patient and in a frequency, intermittently over time, that will suppress the background erythema, and patients are very happy with that. However, that is not covered by insurances, and patients have to pay for that out of pocket, and that becomes certainly a consideration in each individual case.
Can you talk a little bit about differential diagnosis or other presentations that do simulate the...
It took me a while to really conceptualize this Demodex situation, and I had worked with Joe Bykowski on some cases that he had and assisted in reviewing those cases and getting published the concept of Demodex folliculitis. And I wasn't totally convinced until I started looking at this more closely. Occasionally, you will see patients that have been treated for what you think is rosacea, and they've been treated with a combination of topical and oral treatments that you would expect them to get significantly better. Now, as you know, you can consider the fact that they may not be adhering to the therapy, and that may be why they're not getting better. But we often have, good dialogue with our patients, and they tell us, look, I'm using this medication regularly, and it's still persisting my problem is still persisting to a significant degree. And so in some of these cases, if you actually look at these patients, they'll often have a patchy erythema or little erythematous flat papules that have a little bit of scaling or maybe some pustules. And it typically is not only on the central face, but it will tend to extend out, in my experience, also more to the lateral portion of the face. If you look closely at these patients, you may see a few pustular lesions or a few scaly papules. And if you take a 15 blade and you do a microscopy evaluation, I have found in some of these cases Demodex. And you're looking for these patients, obviously, during the day at your office. Demodex typically are night crawlers. They come out at night, at least according to Frank Powell. It's not very often that we can find a lot of Demodex on the slide, though there really is no definitive way to quantify the Demodex that anybody's come up with to make the diagnosis. Simply finding a few Demodex in this case leads me to believe that Demodex we know can be pro-inflammatory and may be contributing to the clinical presentation. In these cases, where the patients have already been treated with doxycycline and metronidazole and azelaic acid, etc., they've tried different things, and it's persisted. And I've had a few patients that their clinicians, before they referred them to me, also treated them with oral isotretinoin, and they got better, but then the condition came back. In this situation where I've found the Demodex, I have treated them with sulfacetamide sulfur. I have also treated them with topical cortameton, which is known to be a weak skaticide. And in Dr. Bykowski's evaluation, he found that several patients were improved significantly with that therapy, and oral ivermectin. And I have had many patients do extremely well and be very happy where they've not done well with the other therapies because they didn't have rosacea. They had a Demodex folliculitis. And that's helpful in occasional cases. It's only in those cases where you don't see a response and you look at them and there's something a little bit different about their clinical presentation. The other situation that you have to be aware of is when patients are using topical corticosteroids on their skin and they may not have had rosacea before, or rosacea is being treated with topical corticosteroids, and it creates a different scenario. It's a topical corticosteroid-associated rosacea-form eruption. It can be an exacerbation or a worsening of pre-existing rosacea, or it can be de novo, in a sense, from the topical corticosteroid. These patients tend to have a much more brisk erythema. They have a suffused look to their skin. They have a lot of intense vasodilation within their skin. And the reason for that is they appear to produce a lot more nitric oxide. And that nitric oxide is a vasodilator. And their skin is much more sensitive. So I will typically not treat those patients up front with any of the topical therapies. I give them, good skin care. I tell them to stop the corticosteroid. I do not wean them down to something like hydrocortisone to wean them off. I tell them, look, you're going to have to go cold turkey. You're going to get worse before you get better. You're not going to like me for a week or two, but then you're eventually going to like me a lot. And I treat them with a systemic tetracycline derivative. I'm typically using anti-inflammatory dose doxycycline, though you don't have to use that. You can use any of the others, like minocycline if you wanted to, or antibiotic doses of doxycycline. I don't see that as an advantage, but some clinicians may want to do that. But I think the key here is not to get too involved topically because their skin is very, very sensitive initially. Then 3 or 4 weeks later, when they're cooled down with the good skin care, you can then put them on a topical regimen. And they do extremely well. And they're very thankful, though, when they have that initial worsening, when you get them cold turkey off the topical corticosteroid, they're not happy during that time period. And you have to make sure they know not to go back to that topical corticosteroid. The third presentation is perioral dermatitis, which to me is a totally different disease than rosacea. It tends to be in younger females, though I'm not going to go out on the limb and define, where the cutoff is for a young female. It's classically described in younger females. It can be induced or worsened by topical corticosteroids, which can happen in a male or female. Occasionally, you'll see males that have perioral dermatitis, and this responds extremely well to oral tetracyclines. I find the anti-inflammatory dose doxycycline works very well, and I'll typically use something very mild topically, like a topical sulfacetamide, though I don't think that contributes very much to the disease. I think the oral therapy is really what's controlling it, and they will typically get better and clear within 6 to 8 weeks. They usually do not recur, but they can recur. They have very sensitive skin. They have a lot of transepidermal water loss, so you have to make sure they're not utilizing anything too aggressive on their skin, like abrasive cleansers, astringents, which are also important not to use in rosacea. Use mild, gentle skin care, and I typically utilize the oral therapy that I mentioned, and sometimes I don't even use a topical sulfacetamide, though they often will like to have, something to apply. And they do very, very well with this particular regimen. But to me, it's a totally different entity than rosacea because it's typically not something that you're going to see persist long term, though it can recur. There is a presentation which you will often see in young teenagers or preteens that I call a perinasal dermatitis. and you'll sometimes see this happen in adults. They present with an erythema, a pink erythema in the nasal creases, very similar to where you would expect to see seborrheic dermatitis. But one of the things that's very characteristic with perioral dermatitis is once you become familiar with that pink color that's so specific for perioral dermatitis, that's the same pink color that happens with this perinasal dermatitis, which is a variant of perioral dermatitis, but they don't have the complete ring or broken ring of pink small papules that can coalesce in the perioral area that you see with perioral dermatitis. And with perioral dermatitis, they'll have a perivermilion sparing zone that lets you know, hey, that's perioral dermatitis. You don't see that in these younger patients. You only see that pink erythema in the nasal creases, and that's often misdiagnosed as seborrheic dermatitis, treated with a corticosteroid, which is really what you don't want to see done. And those patients will do extremely well with anti-inflammatory dose doxycycline or a tetracycline derivative, as I mentioned, as long as they're over the age of 8 years old. And they also do very well, just like the patients with perioral dermatitis do. But it's not seborrheic dermatitis, but it's often misdiagnosed as seborrheic dermatitis, so you need to be aware of that.